All right. Good evening. Hello. Thank you. Welcome. My name's Romi Chopra. I'm an interventional radiologist and endovascular specialist. And thanks for coming out. This is interesting times, to say the least. And what I'm going to talk to you today about is basically how you as a podiatrist, how I as an endovascular specialist and our organizations can really collaborate and help our patient base. And at the same time, how do we make life good for everybody and for ourselves? I've spoken at your organization twice now. I've been friends with podiatrists forever. We share office with podiatrists. And I always start my presentation by saying, isn't it true that we both have a foot fetish? So as we work our way through MIMIT, which is MIMIT Health, actually founded this 2003. It stood for the Midwest Institute for Minimally Invasive Therapies. It's a mouthful, so we've since then grown it into a multi-specialty group called MIMIT Health. We're all over Chicagoland. We're growing rapidly. But what we've done is invested in best of practices in the industry, not just in healthcare, but in real life. So how many of you shop from Amazon? Or should I say, how many of you don't? There's one person here, okay. How many shop at Costco and how many don't? Almost everybody does. So one of the things that these companies have learned to do is they're first customer-centric, which means they're obsessed with their customer. Patients are our customers. I will be talking about that, but we have taken principles from Amazon. I did a webinar a few days ago with Taylor Medical. It's a podiatry group as well that invited me to speak, but we talked about how we as a medical provider practice are using the principles of, for example, like an Amazon, and how we are impacting patient care. So I'm going to describe that to you in addition to what we are doing clinically. Okay. And if there's any questions, obviously you can interrupt me at any time. We call this enlightened healthcare, because I truly believe that as humans, all humans feel before we think. Every action needs thought and feeling. Sometimes you know exactly what to do, you just don't feel like doing it. Sometimes you feel like doing it, but you don't know what to do. And humans feel before you think as you go through this. So patients, humans, you and I, when we have a problem, we go to another human being, not to a building. So these big health systems, these big buildings, these big hospitals, you're all going through a kind of a maze of stuff. And it's all about the hospital itself, about the system itself, versus it being about what the patient wants. So the patient will come to you, it's me as a human being, goes to another human being because I have a problem. And there is a goal, which is to solve that problem. And then we as a group, so you and I together, will collaborate to solve that problem. So that's the paradigm. I'm going to show you in real practice how we are doing this. We did about 400 angiograms last year, all from podiatrists, 99% from podiatrists. How no podiatrist has ever lost a patient that they've sent us. We've done 99 or 98% of our work outpatient. So they're from home, skilled nursing facilities, independent facilities, all the way to obviously if they're in a hospital, but we do less and less in a hospital. So we'll show you how we've worked on building win-win paradigm here. So as you know, I always describe to patients and other people, I say I'm a human plumber because I'm focused on all the plumbing. And I look at anybody else who does other stuff, you're the contractor. So we need to work together. You fix the structural issues and we're in the same team. So if the plumbing's not there, the garden's not going to do well. You can keep fixing whatever else you need to. So we kind of work our way. So, I mean, here's a picture of a real case. Here's sent to me by a podiatrist. He's with all these wounds, all these problems. They're talking about DKA. And if you look at his angio, there's literally no flow in the PT, AT, distally. This is after we opened him just the first time. That's his foot. I mean, we've got patients we've done for now up to 15 years that we've kept them. Here's a patient, this 5-year follow-up. 60-year-old gentleman sent me by the podiatrist. He's like, now this guy's on dialysis. He's got diabetes. We're looking at an amputation, and it won't heal. This guy doesn't want an amputation. He's like, if he's got an amputation, I don't have a foot to treat anymore anyway. So we said, all right. So it came in Jan, and by that he was admitted then. This is in March. It's getting worse in 2013. Non-COVID, I'm COVID negative, just tested. So we do an angiogram on him. Here you see there's an occlusion in the common femoral. There's all this occlusive disease. This is after opening that. This is infrapopliteal. The tibial-perineal posterior tibial, there was no flow earlier. We've opened this. And as we walked our way through this, this is 2020, March. Still got his foot. Now, we've done him a couple of times in between. So we follow everybody. We say, you know, do you have a car? Yes. How often do you take it for service? Every 3 months. This body, you ain't getting a new one, so come every 3 months. But we have learned how to connect with people. If you buy from Amazon, your package is not what you want. You open your app, so we're building an app. You click a button and say, contact us, and Amazon calls you. We're working on that same technology. We're using the exact same platform now and building it up. Just today, the podiatrist office that I'm sharing with sends us a patient on a Friday. Monday, we've already done the case. Everything is done. He gets a text and a message from me. Wednesday, they scheduled the surgery. Patient's back in. That same patient was weeks. He was waiting, went to the hospital, came back, Northwestern, this, that, scheduling nightmare. We've got patient engagement teams. So one is what you do with the procedure, but the other part is really how do we focus on the patient experience, but your experience. That patient now loves you because they got their foot back, no amputation, and you are happy because now on your phone, you just got a message and everything's done. And that's the collaborative platform that we've kind of created. And the other thing was, I hear this all the time. I was speaking to somebody here earlier and they said, you know, the group they're working with is doing stuff from the 70s. A lot of people don't do too much below the knee. We live below the knee. So we'll show you cases of how we do alternative access as well. But to be in the pedal arch is routine. Every case we get a wire down, infrapop disease, especially diabetics, etc. And then we obviously follow them. We took at the prevention. So one of the things we're looking at is, hey, how do we prevent amputation? I've done this around the world. I've been doing this for 30 years. I've spoken in different continents, different countries. I always ask this question of everybody. How many of you for $1 million are going to give me your right thumb? I've never had a hand go up. How about your right leg? $2 million, $5 million. Nobody wants to do that. I've had patients, 90-year-old goes, I don't want an amputation. I'm going to my grave with all my body parts. Just how we are as humans. So amputation prevention is key, right? Now, so as we walk our way through, we know we want to heal those wounds. The cost of amputation, et cetera, is extremely high. But the underlying challenge, the underlying problem, like I grew up in Bombay, India, by the ocean, salt, and all the pipes rusted all the time. Atherosclerosis is rusting of our blood vessels. So when you think of it, if your pipes in the kitchen rusted, that means they're rusting in the bathroom, they're rusting everywhere else. So if you have atherosclerosis, it's happening in your heart, it's happening in your brain, it's happening in your legs. So here's a question for you. Patient walks into your office and says, Doc, I was walking here and I got chest pain. And you know it's angina. What are you going to do? You're going to send him to the ER. Or he says, I just had a TIA. You're going to send him to the ER. But he walked in and said, I have claudication. You got to go walk some more. But the morbidity and mortality for that patient is the three patients are exactly the same. The patients who have known to have PAD will die from a stroke or a heart attack. Amputation is just, and severe PAD is just 2% of all patients who have atherosclerosis. But the cost of that small percentage is high. And you are in a very unique position as podiatrists because you see legs and feet all day. I've spoken to many thousand primary care docs. Almost nobody looks at the foot. And the patient in the office, they're wearing their shoes, and when they're rounding, they don't take off the sheets, and they've got wounds underlying, they've got all these problems, but they don't realize that that's the signal for PAD, peripheral arterial disease, which is the signal for underlying atherosclerosis, which means they have a very high chance of having a stroke and or a heart attack. So, but the underlying challenge is the plaque. So that's why we want to catch them early, work our way through this. And the focus is on plumbing. What you want is traffic, blood flow to go through and carry the oxygen all the way through. And then the question becomes, how do I get blood flow? How do I keep it going? And keep it open as long as possible, right? So if a plumber comes to your house and goes, I want to fix it for 2 days, and then I'm coming back again and again and again, you go, whoa, that's not the way we want it. You fix it how long do you want it fixed? As long as you have the house. You know, whatever that time period is, it's the same. So PAD is a very, very expensive proposition, especially when it comes to amputation. So I always ask this, so close your eyes and imagine, move your right foot, feel it, imagine how precious it is. Now imagine you've lost it. You have an amputation below your knee. Think for a moment how you feel. Think for a moment how it would impact your life, how it would impact the lives of your loved ones, and to think that this is a signal that you're most likely not going to be alive 2 to 3 years from now. And that there's a chance of having one on the other side. Just think of how you're going to go to the bathroom, how you're going to live, how you feel. Amputation is just not a good thing. And it's 48% died 1 year. Half the people are dead in a year. 71% at 3 years. And it costs a lot of money. And people think that, but the paradigm, if you look at Amazon, they compete and collaborate. You'll find it better, faster, and cheaper. That's what we're trying to do in healthcare. So sometimes you will spend more upfront, but prevent downstream costs. So we try to avoid hospitalizations as much as possible. So simple things, we have 3 cath labs now, outpatient. Let's say on average it costs $20,000. I'm just making up a number. In a hospital, it costs $93,000. How do you, and then because the hospitals have their own bureaucracy and everything else that goes on. And people don't realize that PAD costs more than diabetes, coronary artery disease, and cancer. And for Medicare, most of these are older patients, the cost is huge. All right, so then as we talked, a lot of these patients are going to die early, their lives are miserable, so we want to avoid this. And PAD, amputation from PAD is a high number. 185,000 annual amputations, a lot of them don't even get a vascular evaluation, especially in skilled nursing facilities if you go there, and other places because they got other problems. Lifetime cost of one amputation is $500,000. A lot of money. PAD as well, just to put it in perspective, I'm trying to create the case for why you as a practicing podiatrist should say, hey, does this patient have PAD? And while you do that, I'm going to show you in a few minutes, this is actual stuff. We've got 32 practices, podiatrists doing this with us. We're generating more revenue or taking better care of the patient, and patients happy as well. One of the first things is if you look at any population over 10 years, there's a certain survival rate. And that's about 90%, 10 years in the population. When it gets to even asymptomatic PAD, that means you don't know, they don't have symptoms. And that's one thing to remember with PAD, it is not typical. They'll tell you, so most people say they have pain, there are 2 personalities. One is like, oh my God, I'm dying. And the other personality is stoic. They've had babies, they've had kids, they've had life, they've had a tough life. Yeah, I'm fine, I'm fine. But when you ask them, hey, you parked your car and you walked here, what happened? Oh, I stopped 3 times. At the end of the day, my feet killed me, et cetera, et cetera. So most of PAD is atypical pain, and a lot of them are asymptomatic. That's another thing to remember. But severe PAD has a 25% 10-year survival. So it's good to catch it early. Like I mentioned, a lot of them will have a heart attack earlier. But coordinating care, and it's coming down the pike where we'll all be at risk together. So here's a person, PAD, has got a wound, whether you do it, I do it together, we have a bundled payment, and now you and I are at the same risk. So me doing more procedures, we actually lose money. You just keep doing some more amputations, lose money. You do it together, we both get rewarded for the patient being healthier and not having an amputation. That's just coming down the paradigm. We have changed this on its head, just like Amazon has done, Costco has done. We are now totally digitally transformed, where we we see patients all over the place. I have a patient now, I'm not going to violate any HIPAA, but is the father of the Prime Minister of an Eastern European country. Has flown down here for the third time. We fixed his right leg once, left leg once. He could have gone Germany, Israel, anywhere in Europe, anywhere in the US. And his private physician heard me speak and has sent me another patient. So he actually flew him down here. We treated him. He's now back in that country. And we do televisits. Everything is, unfortunately, he decided to go to Vegas after he was feeling so good. Comes back and says, I was in Vegas. I'm like, oh, spokes. And then he flew back. He's got his wife with him. He's got his private physician with him. Guess what? He got COVID. So now they're calling me from there. Luckily, he's doing good. But, so my point is that platform has changed. And now the scope has changed. And one of the things we've been doing is working with podiatrists to do very effective screening. Some of you have heard of the PadNet biomedics. There's the old stuff, but that has evolved significantly into a platform. Now we have, I think the last number is 33 practices, podiatrists. They have this unit in their office. We identify the patients that should be screening. Your medical assistant or somebody does that. Those reports show up to us. We look at it. You bill for it. You collect it. We ensure that it is. It's all legal. It's all ethical. I pay the fee for it. You have to pay a small fee so that it's legal, but there's good revenue at the end of the year. But we catch all these patients. And it's links into a digital platform, so I will show you that as well. And here it is. So this is in your office, for example. This is our system. If you go on Twitter, on LinkedIn, etc., just look up my name or MIMIT Health. You'll see we've become Salesforce.com. It's a multi-billion-dollar organization. And in the provider space, we've become their poster child of how we've done this, where we are connecting with docs and patients, but all centered on the patient. So this has been something, and any of you that get interested in that will happily work with you. So who do you screen for? So anybody who's at risk. Who is at risk? Diabetic more than 10 years, people above 60. I'm crawling up there slowly. I think I have another 10 years before I hit 60. I'm not sure. But dementia kicking in. Above 50 with their smoking. So I have friends who work in other parts of the country, in the Bible Belt and those areas. Holy smoke, between their diet and stuff, they just can't stop doing PAD work there. But anybody about 50, especially smokers, tobacco chewers, anybody with an ulcer, they talk about leg pain, could be atypical. It doesn't have to be the classic claudication. Rest pain. Now, in vascular world, rest pain means, on the day you're walking, your blood pressure is up, the stimulus, you got a sympathetic response. But when you sleep, everything calms down, your blood pressure slows down, everything goes down, you're relaxed. But that also gets the blood flow to the foot kind of less than it was before. If it goes below that critical threshold, you get pain, wake up. When they wake up, the first thing they do is they shake their head, they dangle it over the bed, and they walk around, they feel better. That is typical vascular rest pain. It's a sign that things are getting bad. You got to check it out now. So that's one sign. But anybody, if you're doing, and I'll show you a case or two where, like I said, we work with a lot of podiatrists, and one of them called me on a Sunday. He was panicked. He said, smokes, he had this lovely lady, had done some work on her metatarsal and had a black toe, and they were freaking out. They were calling him. And he said, can you see her? Monday morning, we saw her, and we did an ultrasound, actually had a hidden, when I say hidden, kind of called common femoral SFA occlusion. That next morning, we had her in our outpatient lab. It was open. And so, and then now, all she had was some debridement off the tip. It was already gangrenous, but we saved that limb. Since that day, he never does any surgery. If there's any doubt, unless they're pounding pulses, he does a PadNet. If there's any doubt, we see them first to clear that vascular is good. So fix the plumbing first, so obviously the wound won't heal. And our goal is, hey, let's keep some good blood flow going, keep the pipes open, and combine it with medical therapy and everything else. And surgery is not the gold standard anymore. all of us are slowly creeping up the age where we probably have some PAD. Do you really want to get filleted like that? Versus, I'm going to show you a case in a bit. But I do it from the wrist, transradial. Infrapopliteal work. I'll show that to you in a minute or two. So this is definitely not the gold standard anymore. Technology has come a long way. Thanks to Boston Scientific for hosting this dinner, but they make a lot of these kind of tools. Obviously, they're a public company, and I showed you this picture earlier. Most of these, we're doing this outpatient, 98, 99% of these. Rarely do we admit them in a hospital now. We have cath lab anesthesia. We don't do general anesthesia, of course, all deep sedation. They go home the same day. We have closure devices, closes the access. I can puncture the dorsalis pedis, posterior tibial, peroneal, popliteal. I'll show you some of those cases. Radial artery. Common femoral is, of course, the most common. But even there, now we have closure. So I'm putting a stitch in the artery through a catheter. They get up and walk. Once they're up, and they go home. So that's absolute routine now. And something like this earlier, this was a definite amputation. Now we're opening all of these up. And you can see that we're getting perfusion down to the foot. Show you a couple of case studies here. So as I mentioned, we were focused on, let me go back to that. Just open the case study. There we go, okay. So this is that 69-year-old I just told you that the podiatrist sent me. Suddenly got blackening of the toe. I'm gonna show you the video here. So this is me getting into the common femoral, do the angiogram. Now this common femoral artery had a hidden lesion right there. And so we got over the horn. This is all outpatient. Get in fast with the wire. That's orbital atherectomy. Basically multiple devices. You have tons of toys too. Open up that artery, you can see the blood flowing through fast. Then this SFA is also occluded. This was a guaranteed bypass in the old days, and it's got infrapopliteal disease too. And you can see that, so we've gotten through, and now I got to open this up. So how do I do this now? Because the femoral is open, here's a wire going down. As I get through that SFA, I got stuck. Like, darn, can't get through. I just can't get through. So in the old days, they would say, all right, take him to the OR, do a bypass. What we do instead is actually puncture the popliteal artery. Just turn the leg to the side under ultrasound guidance, get on in there and do this. I'm just showing you, we have some other fancy devices that you can try and with the needle get through, but it's not working. And our mantra is do it better, faster, and cheaper. So this is a puncture in the popliteal artery. And then from below, from the popliteal artery, I've gotten through. And now I've got a little railroad going from the femoral artery on one side to the popliteal on the other side. And once I've gotten that kind of thing through, I'm putting the angioplasty, the stents, and everything else that's possibly necessary. The bottom line is I got to keep the blood vessel open. And you can see now that what was occluded, this is a long 30-centimeter balloon. I'm dilating up that artery and opening up, and there's the flow through it now. Now, and the goal after this is how long can I keep this open? So obviously we survey it. So we have patency data on this, 80% at 5 years. So as we work in our way through this, that's a stent being deployed. As we work through the stent, I'm just going to move forward. We do the angioplasty again. And now if you look at the blood flow, how fast that is. And when you're doing your surgery, if you have to debride anything, you want to see blood squirting out down there. And you can see the flow as it's speeding through, that we've gotten that flow there. Now, if I had to, I can puncture the popliteal artery, the posterior tibial artery, the peroneal artery, whatever is necessary. But then we close this with the stitch in the catheter. There are many different devices that do that, but that's what we call closure devices. Here's another example I'm going to give you of a 75-year-old with diabetes. Yes.
Would the ADMET device have detected that?
Yes, actually, that's what detected it first away. It was done after she got some problems, did it, the waveforms are low. The PADNet device is nothing but plethysmography, telling you what the waveform is. Just like you do your pulse ox, but it's doing in the thigh and the calf and toe. And you say, hey, this is not good, something's wrong. But he didn't do it before. You would catch it before by doing PADNet. So here's just to show you how we do. This is a patient who already had an amputation on the other side, and now they're trying to prevent an amputation here. So on the ultrasound, I've gotten into the popliteal artery. I'm now working through the popliteal artery. And I've gone up, opened up the femoral, the SFA, and there's a tight lesion over here. Done the atherectomy again through the popliteal. This is what it looks like as we're doing the device. These are just toys like you have. You have some toys that you like to make the noise and play with it. But the goal here is how can I keep this open? And you can see how that blood vessel is open now, and we've actually prevented an amputation. You can see how fast that flow is. And that's what you want when you are operating, that tissue has perfusion and it's going to heal after you've done whatever work. First of all, you shouldn't have an amputation, but if that happens, you know, here's another one where disease like this earlier. So this patient will have a wound around the heel. So we go by angiosomes. So this posterior angiosome, you can see the posterior tubules are occluded. The perineal has very poor flow, so they're going to have, and then the anterior tubules are occluded. In the past, this was an automatic BKA. Now, if you look at it, we've gone right through and opened up that. So in the posterior tibial, anterior tibial, perineal, being down in the foot, in the arch, is just absolutely routine. There's no reason why we shouldn't be doing that anymore. Again, just another quick example of how we open all the vessels below the foot, below the ankle and into the foot. I want to work forward to, again, similar example. We're opening up the flow. But this is what I want to really show you. Alternative access. So radial artery, pedal artery, which is dorsalis pedis, posterior tibial, perineal as needed, and the popliteal arteries. I'm going to show you this patient. Imagine working through this belly and the potential complications. She's in pain. She's bent up like this. It's just very hard to do this. And the more then you got to sedate them higher, all the kind of problems. So we actually did this case prone, because when we did the SFA, you can see, I'm going to show it to you in a bit. Here's the video for it. We prepped his popliteal. I'm going to work through his radial. He's actually laying there prone. I'm going to work through the radial artery and then work my way down. So now I've got access into the radial artery. And I'm able to work my way all the way down. And I'm doing work from the radial artery. But then I access the popliteal artery. Now, and then, you see that like in the last case, the SFA is occluded. From the popliteal, I go up. And from the radial access, I come from the top. I connect the two. I have a wire that's out from the radial artery all the way down into the popliteal now. And now I have a long sheet that's 150 centimeters that goes from here all the way down into the popliteal artery. And then I'm now actually doing an atherectomy in the tibio-perineal trunk from the radial artery. This would have been a big surgery for this patient. Most likely won't even have had, you know, the success. You saw the belly, obesity, diabetes, all that stuff. So this is the angiogram before. This we're doing the atherectomy and the angioplasty, and that's the result later. Amputation prevented, cost $25K total to patient and insurance. In a hospital, this would have been a few $100,000. If there was an amputation, the total cost of this is $500,000. Just to kind of show you how it is. So that's how we've been teaming up with folks to kind of make sure that we can get these patients identified early, treated early, and get them right back to you. At the same token, there's value for you, which means you're generating revenue, you're happier, it's easier, it's faster, and it's cheaper for everybody. That's what we call the Amazonification paradigm. So I'll talk to you a little bit about this, and is that here's the paradigm of being patient-centered. That's what Amazon does. That's what Costco does. All the big companies do. They are obsessed. And try this out. Just on your app, order something from Amazon and just say, contact me, and watch how it goes through. It's unbelievable. 90% of them are in the Philippines. So I know a few words in Tagalog, and I know that they're there. And they go out of their way to please you. And I give you a simple example. I ordered some stuff together and came up, and there was a bottle of oil, and that leaked. And I had a can of some shakes, whatever, and obviously the oil leaked, and I had some packet of something else. I just got a little irritated that it happens. I had nothing better to do. I pressed the button, called me, they called me. And I said it leaked. She said, oh my God, I am so sorry. And she said, you know, I'm gonna send you a new oil bottle anyway. And what else was in there? And she goes, I'm gonna send you a new one. I'm like, I don't want it because that was a steel can. There's nothing wrong with that. But so I said, no, that's fine. Another example, now this is a minor thing. I order as a gift for somebody, almost a $4,000 coffee machine. And it gets lost by shipping somewhere. The building is giving me a hard time shipping. So I just called Amazon. I said, they can't find it. Next day, they sent me one. Next day, $4,500. Like, are you kidding me? And then when the other one came, I said, send it back. They said, no, keep it. Now, which hospital? My point is, which hospital does that? So I've been on hundreds of boards and panels and stuff. And I remember talking, I'm in New York, there are all these docs from all these institutions. And one doc says, I do this, one does do this, and one that says, I do this. And they're talking. I said, guys, I have just one question. Whatever you just said, nobody talked about the patient. It was just about how big your hospital is and how you are and how much money you made and whatever. I said, if Amazon did this to you for $10, you would be pissed. We do this to our customers all day. So this was a few years ago. So for the last 5 years, we've been working on this paradigm. So we do all these little things. I won't go through all the details, but the idea is centered on the patient, collaborate with you, connected with the patient. Patients can text us, patients can email us. We have care coordination teams. We coordinate all of this, every activity that's needed. We know which podiatrist is part of which care and what they're doing. And if you willing and agree, then we give you access. You can actually see the care plans and work with us, and you get notification. You never lose the patient. I showed you this already. We've tested this out. We have 30-some clinics now, and it's working very well. So the patient comes in, they do it, they screen it. We see the test, you read it, you bill for it, you got revenue for it. We've identified which patient needs to be screened. So they're either mild, moderate, or severe. Severe means there's a problem before you operate, so those are separate category. Mild and moderate, we've identified their PAD, we do the ultrasound, we make sure. Now this is a chronic disease if they're diabetics on top of it, so then we help them manage this overall, work with whoever it is, but make sure they come back to you. Because the diabetic who has PAD is a smoker and he's a young guy, you're gonna clip his nail and not realize he's asymptomatic. He's got neuropathy too. You're gonna clip that nail, it's gonna get infected. And I've seen those things go off a cliff fast. And you identify those earlier, and before you know it, you have it helps the patients, helps everybody. We follow this principle called the 6 rights. So whether you watch any sports, you'll never play football in a baseball arena, would you? You need the right structure. You wouldn't have baseball players playing hockey. You need the right people. You need the right processes. But the most important is you need the right information to make the right decision at the right time. So you are going to operate on this foot. And you're not sure, but if I get you the information at the right time before you operate that there's patients at risk and there's potential PAD, and we fix it, make the right decision, patient's better off, you're better off, lawsuits go down, everything gets better. And that depends on the structure and the process we put above it. So we've played this out now with enough podiatrists, and it's been a massive success. And so I'm sharing this with you. We also look at what we call the 6 pillars of success. Amazon does it, Costco does it, any world-class organization does it. And what do? Whatever product or service you get from them will be top class. Try it. Go to Costco. Let's assume for a moment you don't like it or there's a problem. They will give you excellent customer service. A 93-year-old mom wanted something. I took her to Costco. She picked up something. She liked it for 3 days. She came back. She worked for 3 days. Goes, God bless her soul. She passed away. She goes, I don't want this. I'm like, all right, Mom, don't worry. I'll get you another one. She goes, no. I'm going to go with you and return it. I'm like, oh, Mom, please don't. No. So off we go to Costco. Her caregiver, me, and my mom. We go to Costco. I'm embarrassed as heck. Guy with the turban walks in with the jacket. I'm like, I'll return this, and they all know me. I come there so often. So I'm looking at her going, you know, my mom wants to return that. And she's in a wheelchair, standing there, sitting there, looking at me, and goes, you're going to return this. So she said, no worries, sir. Just go get another one. And took it right back, right? Customer-centric, excellent customer service. I mean, you can go all the way. I got another example, bought a TV. They, you know, usually you get a 1-year warranty. They extended by another 2. At the 3rd year, just a few days before this, the TV, something happened, goes wrong. You call them, concierge service, to go, just take it back. Took the TV off the wall, went to Costco, TV's not working. They look it up, yeah, it's your TV. Go find another one, but they don't have their model anymore. The model which is comparable is now $500 more. So they say, it's yours, and by the way, we've extended your warranty for another 2 years. That is customer service. But who gives those to? Employees. So you make sure your employees, so they say you treat your employees like you want them to treat your best customers. You walk into a cath lab in a hospital, they're all fighting. That's why I do very little in hospitals anymore. We're all aligned. We're all rowing in the same direction. Patient, podiatrist, family, make sure everything's good. So that's employee satisfaction. 4th pillar is fiscal responsibility. Costco, Amazon will always give you savings, but they make a lot of money too. Win-win or no deal. Think about it. Amazon, you go on there, say, here's Prime, this is what it costs. You can buy it from other people, but they'll save you money. They tell you what your savings are. But Amazon, that Bezos is a trillionaire. Almost, but he's still a lot of money. The 5th, which is the most important, they are constantly improving and constantly innovating. They're talking about drones, this, that, you name it. So in healthcare, who's doing this? So one of the things we've done is we've tried to do this in our small little world and bring this about to success. I'm a vascular guy, so that's kind of what we've been doing this. But the 6th is the most important. They sustain this. They do this all day long. You go to Costco, have you ever seen an unhappy Costco employee, at least facing you? Never. And they are constantly improving their systems. And so that's the paradigm that's coming into this. Now, I could talk forever. I have the gift of gab, but thank you for your attention. Take home points. Team up with an endovascular specialist. We'll work together in identifying these patients who have underlying PAD early, get the plumbing fixed. It's a win-win deal all around. Thanks again. It's an absolute pleasure. Any questions, I'm happy to answer. Yes, sir.
You show us, you know, the Chopra and all that.
Yeah.
What's your follow-up, and how many of these reclude?
Definitely. So it also obviously depends on the disease state. So you have a 93, you're not looking for 10-year patency if you have a 93-year-old. You just don't want them to have an amputation. If you have a 40-year-old, you definitely want them to be patent as long as they're alive. So how do we do this? Do the procedure, next day they get a telehealth visit no matter where they are, nursing home, we call them, we talk to them. We put them all on antiplatelet agents, etc. But we follow them for life, at least at the minimum every 3 months, or if something's wrong, they call us before. Now, depends on which vessel. So the larger the vessel, the longer the patency and the higher the patency rate as it gets lower down. And then comes the goal of treatment. So if you have somebody who's got a wound and got infrapopular disease and a diabetic, you want to heal the wound. They're not going to run a marathon. We know that. So there you want to get enough perfusion to heal the wound and keep it healed, and we surveil them. So it depends on the disease, depends on all the other factors, but we don't take the eye off that ball. I hope that answered your question.
I have a follow-up question.
Yes.
So when do you refer vascular surgery?
So,
No,
no, I'm waiting for you.
And is vascular surgery any better sometimes in the patencies of these arteries? And thirdly, do you worry about pushing thrombi through the vessels?
So let me answer your first question. So we're a multi-specialty group. So we have cardiologists, we have vascular surgeons. So we're independent. So we don't have this fight between vascular surgery, cardiology, whatever. It's what tools. So if a plumber comes into your house, I grew up in India, I remember when a pipe broke or there was a problem, they broke the whole friggin' wall down, they found the pipe, they changed the pipe, and they that's surgery. Now what do? They come out, they look, do roto-rooter, fix it. 90%, 98% of all the 90 to 98% of all vascular surgeons, Vascular Surgery Society, all do endovascular as well. And the very few do fem distal bypasses or fem-pop bypasses. So fem-pop bypasses have dropped really dramatically. So when does somebody, assuming all are available, when does somebody get a open surgical procedure versus endovascular procedure? That's the real question, not a fight between specialists. So if I have tried it, I've opened endovascular, it's not staying patent, and I absolutely need, you know, some conduit to go down there, then open surgery. But we did 400 cases last year, 300 and some in the year before that, and I sit on many panels, be a part of the Society of Vascular Surgery. So even as an endovascular guy, as an interventional radiologist, I'm part of the Society of Vascular Surgery Vascular Quality Initiative. And we found that more and more is endovascular work. So it's rarely that you need to open these days for below intrainguinal disease. Does that answer your question?
Okay. Does their work ever stay more open?
Say it again?
Do the vessels stay more open?
So not necessarily. That's my point. That's why if you look in the surgical literature now and look at all the surgeons recently trained who are at their best of practice, 99% are doing endovascular work. Rarely will you see somebody just go straight to a bypass anymore. And this is published data. This is not me making this up.
Do you ever refer to a
Yes, all the time. So I've had a patient who I opened him 5 times and he's not doing good. This just shuts down. So I called, I have a bunch of vascular surgeons that work in the city. I said, this guy's a complex guy. He really needs a fem distal bypass. So yeah, sometimes they're coming too late. They need a fasciotomy. And you can say, hey, we can do, that's something that, you know, needs to be done with open surgery. And usually it's a combo of the endovascular and the open surgery. We're way past that bickering and fighting of, hey, I'm a surgeon, so I only do this. It's all. AAA procedures, carotid procedures, all the surgeons are all moving to endovascular. Any other questions? Yes.
We just have the patient call the office.
Yes.
We just have them call.
Yes. You can call the office. You can go online. You have our numbers. Call us. If you don't get the right response, you call me. I make sure it happens. Yes. Yes, sir.
Go a little bit more into what it takes to really, from start to finish, to say, hey, I'm thinking I want to put your, in my office.
Yeah.
And direct you go. So do we have a better understanding?
Yes. So just some framework. I have no financial interest in that company, Biomedics, but we use their device. It's called a PatNet, as you know. But basically, what is it? It's a box they give you, and it's cuffs along the leg, and it measures the waveform and the pressure in the legs. Right? So that's the tool. And they will lease it to you, or you can buy it outright, or however that is set up. They will help you go through your EMR or whatever that is and give you all the criteria to identify which patients need screening. Then the rough numbers are that if you have 2 studies done per month, you pay for the device. Now that device, once it's set up, your medical assistant is trained, no doc does it, but when the patient comes in, they have a questionnaire, they say, hey, I'm a smoker, I'm diabetic, I got this. Okay, this patient needs that. Your medical assistant will do that. That study from the device shows up. I get a message. It goes onto the platform, and we get a message saying there's a PatNet study to be read. So we can look at it on a handheld everywhere. We read it. If it's normal or mild, we say mild. If it's moderate or severe, we say, hey, this is moderate or severe. Recommend further evaluation. So you can send them to me, send them to somebody else. Once they have that, you bill for the technical part of the study. You get reimbursed for it. I read it. It's a small fee, but we bill for the professional part of the study. And then obviously, let's say you have a problem with the device. Something's wrong. 800 number, they call you right back and they give you the support. They train your staff. They figure out all this. So I know some folks, and perhaps even you had a Biomedics years ago. That company was bought out. This is now totally new. It's now on a platform. Now we pay the license fee for the platform. That's why you are now on our network, and that's how we connect with you for this part. But we see the tracings, you see the tracings, you see our recommendations. If you decide to refer the patient to us, then you come into our network, and then all the things that I described to you. Yes.
Who reads these? You read them? You read
So-
all of these?
Do
Who
I
reads these?
makes the device?
Now, who reads?
Reads. So we have all our radiologists, whoever IR surgeon, whoever is on our team reads that. If you're on our platform, one of us reads it. But if you're not, you could be doing this with somebody else, they read it within 24 hours. And if you want something urgent, somebody just calls us and say, hey, that's urgent. Can you read this for me sooner?
Can you use these for DVTs too?
No. This is just arterial waveform. This is just looking at what's the arterial flow and what's the pressure in the leg. That's not an ultrasound study. That DVT is separate. That's ultrasound imaging. Did that help understand the structure? Yeah.
So when you do a PADNET exam on a patient, I have one in my office.
Yes.
It's basically a screening.
Yes.
for PAD.
Yes.
And if they do have like a bad ABI or waveform, then you do an angiogram and determine what.
Not right away. You actually send them so we can evaluate them, because sometimes you can have a false reading on an ABI. You can have some errors. And then you want to make sure you have a clinical evaluation that matches, and you do the ultrasound to see, is this really significant? Then we assess to go, don't just jump to an angiogram. So, we're not treating the waveform, we're treating the patient. So if you have a patient who has something's going on with the toe pressure is low, I can't feel a pulse, the PADNET caught a lower reading, lower waveform, we do the ultrasound, we go, hey, that anterior tibia's occluded, diabetic. Do the ultrasound, say, now this patient would benefit from an angiogram. So that's the process. So PADNET is purely screening, and then we take it to the next level from there. And you don't have to do it just with us. Like I said, I have zero financial interest with biomedics, but we use them a lot, and so we collaborate. We've done this even with primary care docs, but not as much as with podiatrists, because all you see is feet all day long. We're covered. Excellent. Any other questions, comments, thoughts, ideas? Nobody threw anything at me, so that's a good sign. Excellent. If not, thank you very, very much indeed.